Let's get into part 2 now.
If I quiz a colleague in a teaching moment, they'll forget the other maxilla. You hear people in your conferences talking about the maxilla, the maxilla. And I really think it's important to be reminded of the two halves. It's the maxillae. We should know that in the brachy or the wide faces, whatever is the average number, it's supposed to be about 2 millimeters more. The dole is actually 2 millimeters narrower. You've got a number, and that's useful. But in your mind, think a little bit more beyond that. It made it clear to Ricketts and I, the intermolar width and all these differentials are different for each skeletal type at different ages. That's why we make it important to think of the skeletal type when we're planning our treatment and what our norms are. We're going to expand when the teeth are young. If we're going to help the asymmetry of the midface, getting in there earlier, we can do much more to make that symmetric. We keep the arch wide, keep the jaws forward, so it's not just the width, it's the whole perimeter. A little bit of width gives us more perimeter of the arch, more space for teeth. We know from sleep medicine that the kids that are snoring, that have small jaws, they need to have some kind of maxillary and mandibular orthopedic widening, but also forward placement. If the front portions are all brought forward, we're helping our airway and our adenoid region. It's not a substitute for a procedure. We might actually be able to shrink that and overcome that without actually surgical intervention, even though we highly favor that. In this stage of it all, it looks like we're out of control. The upper looks forward and the dentist looks at it and says, wow, I don't think they know what they're doing. You've got more gap in the front now. But notice the lower front teeth have all compensated in. Now we can overcome that, upright the teeth forward, and end up with the final arch as an adult being this forward projecting arch that we call beauty too. We want smile projections. I wrote articles on non-extraction for the upper arch, lower arch. These were in the World Journal about 20 years ago, making the point that we do these things early and we favor making room for all the teeth, but developing the jaws so the teeth have the proper structure and support. For every 1 millimeter width, we get about 2.3% nasal volume increase. Is very powerful. Look at how much more flow we get for the airway. And that's the benefit. It's a smooth laminar flow, not turbulent flow. If it was done by classic orthodontic measurements, there would have been teeth taken out because of the degree of crowding. And yet we do all this and it opens up the airway and gets that nice full arch. I believe in 3 phases when it's appropriate. The deciduous phase, and then the late mixed dentition phase, and then the final finishing. All the teeth in and a big wide face. That's where the beauty comes from. The upper is a template, so if it's being widened, the lower has to be widened to match. I don't just widen to make the upper fit. The lower has to be made optimal and decompensated. I've said that for years because my periodontal friends would criticize this. So I never would call it expansion, it was always decompensate. Even on the adult, the non-grower, we're going to decompensate the arch, gently bring it to be upright. We gain room for teeth that way. In the end, both arches are wide. He's got this big wide smile and functional face. In this case, the upper arch was being expanded, and notice the lower arch wasn't being treated at all. The upper was done. He's told, you're good till your teeth come in, and I don't quite agree. All these things are made better by giving more attention to the lower. So we need bimaxillary expansion, upper and lower. I want to see a nice wide arch, and that's an aesthetic guide for us. We don't want to see side teeth leaned in. We want them upright like the pillars of a coliseum, just nice and wide and symmetric. Visually, there's a beauty to that. The main thing here is the buccal corridors. You see the last teeth nice and upright, big wide arches, nasal breathing. He sleeps well and a happy guy. That's just so humbling and enlightening to help a kid like that. The face mask isn't for orthopedics for class 3. We're using it in class 2 to bring one or both arches forward. We get these nice big wide smiles. They have smiles that just have projection in life. Let's get the air box working, get the nose working, get all the mile underway, get the airway unlocked, get the mandible unlocked. Look at his craniocervical change. The neck flexion, head extension, look at the curvature. How much improvement by getting the jaw forward and everything unlocked. That's huge to me. It's a craniocervical benefit. He says he's sleeping good. Now he's an athlete, he's active, he's doing things, he's growing because he's sleeping. So it's airway focused orthodontics.